Welcome, my dear students, to R.A.T.S for PGs. I would like you people to kindly observe the topic on the screen. If you are confident of answering it, you can skip this session. Normally, topics such as these are a little complex. I won't say complicated. And to answer these, we would require a sense of organization. There should be a recall and reproduce. And these subheadings are mandatory as far as this topic is concerned. The normal structure of the testis and the associated organs. So you should know that there is a spermatic cord, and then there is a sac, an epididymis. There is something called the R.A.T. testis over here, and then these are the various tubules or the units. The head of the epididymis, the tunica vaginalis, and the cremaster muscles for reflex. The same thing is being depicted in a more simplified manner over here. The bladder, the seminal vesicle, ejaculatory duct, etc. They play their role along with the testis. So these you people should be having in mind. Coming to the histology next, you find that the testis itself is a complex assembly of units in a regular form. I find that each of these is a unit, and I should have in mind. This is more or less analogous to the various acini and the ductules that you find in the breast. Coming to the schematic picture of it, I find that there are two basic components. One is the germinal epithelium and another is the Sertoli cell. And after the spermatozoa are being produced, they adhere to the Sertoli cell for nutrition. Limiting all these will be the basal membrane, external to which we have got the Leydig cells and maybe the fibroblast and a few myoepithelial cells. This we shall always have in mind, the various components to which we shall go. Continuing with the histology of the testis, composed of 250 lobules, and each lobule has got 4 to 5 seminiferous tubules, the stroma and the Leydig cells. The diameter varies from 60 to 150 microns. In the case of adults, it is 150 microns. And externally, we have seen the basement membrane, smooth muscle, fibroblast. Fibroblast, when I say, they are sparse. Also, there are the Sertoli cells, otherwise called as the sustentacular cells, which are more pyramidal with basal nuclei. And this is a picture of the seminiferous tubule, showing the Sertoli cell over here, and this is the germinal epithelium. My professor used to say, roughly there used to be a ratio of 3:1 for the Sertoli cell. It always seems impossible until it is done. Nelson Mandela. Why did I put it over here? Now again, the question to the house is, how can we improve our answers? This particular question we shall revisit towards the end of the session. Coming to the development and histology, there are several hundred seminiferous tubules, and we find different stages of spermatogenesis. Various immature and mature spermatids are seen. There is a fine basement membrane. The interstitium composed of fibroblasts and macrophages. Leydig cells with vacuoles and crystalloids of Ranke. So what is so great about it? I was shocked to find that crystalloids of Ranke was a university question in the MD paper. So IQ is equal to UQ. So this is the normal histology. As I told you people, there is the Sertoli cell, then the germinal epithelium in various stages of maturation. That is exactly what we are seeing over here. So there is a spermatogonium, primary spermatocytes, secondary spermatocytes, spermatids, and then spermatozoa, which get adhered. And there is also a meiotic and a mitotic division that goes on. This is the basement membrane, external to which we have got the Leydig cells, capillaries, and the myofibroblasts. A beautiful schematic diagram, which I feel we can draw and get the benefits. What are the causes of male infertility? And this is a stunning chart. How to read such ones? Always we find that such charts or tables are staring at us. And the method of reading, I deciphered one. It can be something that we know or we are familiar with. For example, gonadotropin deficiency, Kallmann syndrome, certain things that I know. If you are comfortable with some, choose your own. FSH deficiency. Then there can be a pituitary insufficiency, hypoprolactinemia, growth hormone deficiency. Certain things that we already know, we can recollect. This is what we know already, a Klinefelter syndrome. Also, cryptorchidism, Sertoli cell-only syndrome, chemo and radiotherapy. These are all terminologies that we know already. Coming to this side, there can be a block in the ductal system, a cystic fibrosis or a mucoviscidosis. And there can be an acquired block also, anti-sperm antibodies or sperm immobilizing antibodies. These are things which we can have in mind. So already you have got a wonderful list with you, which can form a good part of your answer. A nice cartoon that I picked up. This gentleman here is supposed to propose a marriage, the wedding goes on, and also he finds that there is another profession that is running, maybe like doctors. There is an actual business and a side business. Marriage counseling is also taken up after the break of the marriage. This is yet another table of it, and I would like you people to kindly choose whatever is comfortable to you people. For me, for example, torsion of the testis, I know mumps orchitis, I'll be knowing. Irradiation, I'll be knowing. Any of the malignancies. Also, any form of masochism or a chromosomal abnormalities. Administration of steroids, other drugs, whatsoever. Chemotherapy. So, try to form your own list. Write it down and memorize them again. This is a wonderful flow diagram. Always when we are asked questions about infertility, straight away we plunge into the organ and get lost. So you got the testis somewhere over here where the spermatogenesis goes on. But then there is a central axis which we should be cautious about. For example, there is a hypothalamus over here, pituitary. Gonadotropin releasing hormone is there, and from the pituitary I will be having the follicle stimulating hormone and the luteinizing hormone. Follicle means it straight away goes to the ovaries over here, and it can also stimulate the Sertoli cells, and it produces the estrogen. There are two components of it. One is called as inhibin, which prevents further activity, activin, which promotes further activity. On the other side, I have got the luteinizing hormone, L for L, Leydig cells, from which testosterone is being produced. Also, the growth hormone, which can promote spermatogenesis. So, this is one that we should have in mind. And we are not stalwarts in biochemistry or so, but then this is a wonderful chart that I have produced for you people. Kindly know the common enzymes or hormones which are associated with are topic. For example, follicle stimulating hormone values are given, luteinizing hormone, testosterone, so on. Also, you have got the growth hormone over here, the values of which are given. I would like you people to kindly memorize all this as well as the growth hormone over there. This is a wonderful play diagram which you people can draw easily. Hypothalamus, the hypophysis from which you have got the luteinizing hormone acts on the Leydig cells, follicle stimulating hormone which can act on the Sertoli cells providing the nutrition. And then this will be the germinal epithelium over here. Finally, there is a testosterone that is being produced by the Leydig cell, which again acts on the germ cells. So these enzymes are of paramount importance. If there is going to be any hindrance to it, there can be an infertility. Now, what are the modes of examination or analysis of a case of male infertility? These are certain headings that you people will have to know. PISA, PISA, TESI, and MESA. So these are the names given over here. Testicular epididymal sperm aspiration. Then percutaneous epididymal sperm aspiration. Testicular sperm extraction. And microepididymal sperm aspiration. And these are the things over here. This is an aspiration. This is from the epididymis. This is a micro aspiration from the epididymis. And this is a small bit of biopsy that is being taken. So these are the various modalities of obtaining the sample. So generally, what are all the indications for this? One is an azoospermia, total absence of the sperm. The different terminologies of oligospermia, etc., we shall be seeing in a case of semen analysis. Less than 20 million sperm per ml of seminal fluid in 2 consecutive ejaculates is supposed to indicate a oligospermia. And FSH greater than 2 to 3 times, it can interfere. Also, the functions of the sperm, motility, etc. Chromosomal analysis may be mandatory in some cases. There is a condition called as obstructive azoospermia and non-obstructive azoospermia. Non-obstructive is confined within the testis. Obstructive is things are all right, but still you do not get the spermatozoa. And in any case of infertility, these are certain things which we will have to need the details about. A complete history, a physical examination, genetic studies, and hormonal profile. It is a total network, and anything wrong anywhere can lead to a loss of the ultimate product. This is a repetition of the same. So I got the hypothalamus, the pituitary, gonadotropin releasing hormone, and FSH and LH acting on the testis and the ovaries, and the negative feedback. So there is a central axis in the testis that can be non-obstructive causes, and there can also be obstructive causes. Try to recollect and act on these subheadings. So what shall be important will be FSH of greater than 2 to 3 times, in which case you find that it is not warranted. This has to be corrected. Harvesting of the sperms and intracytoplasmic injection. This is a step that has been proven recently. Then replacement for in vitro fertilization. Also, you people will have to differentiate between the obstructive and the non-obstructive pathology. I would like you people to kindly recall the various procedures over here. For example, testicular sperm extraction is being done straight away from the testis, from the seminiferous tubules. And what are the uses of any of the extraction of these materials? 1, I shall be studying the histology. 2, the material obtained can be used for cryopreservation, and this is done in a case of sperm extraction. Later on, a molecular diagnostic examination can also be resorted to. So these things are needed. Something it will be micro-assisted, Certain things can be biochemical assisted, certain things will be at the molecular level. This is a normal tubule that I am seeing. So you are finding the spermatids over here. There can be the Sertoli cells, the pale nuclei which are more basally located. And I told you that there is a ratio of 3 germ cell to 1 Sertoli cell. So this should be borne in mind. Here I find that the basement membrane is a little thick, but okay. But in this case, I find that there is a marked thickening. There is also a fibroblastic proliferation. And within the tubule, I find that there is a monomorphic population of pale cells. I do not find the small multi-layered germ cells over here, which means it can be a case of Sertoli cell only syndrome, thanks to WebPath. This itself can be a slide for you people, or it can be a question for you. And coming back to the causes of the male infertility, we have already mentioned. It can be pre-testicular at the level of the extragonadal testicular disorders of the hypothalamus, adrenal, or the pituitary. Testicular, it can be primary. It can be genetic or environmental. And post-testicular, there can be obstruction of the various ducts. Also, look at this picture over here. This is somewhat replicating the dynein arms that I find in a case of a cartilaginous syndrome. In the cartilaginous syndrome, there will be only these sets of or the 9 pairs of the ciliary bodies over here and the radial spokes which are connecting. Whereas in a case of sperm, you find that there can be an outer dense fiber also. So a defect in this can be studied. So a beautiful schematic pictures, animations are tremendous, overtaking us. So the same thing over here. Also, when we study histologically, there are certain other things which we will have to look into. There can be acute on chronic granulomatous orchitis. When I say granulomatous orchitis, you people will have to recall various conditions. It can be tuberculosis, or it can be mumps, or it can be leprosy. The indication for the biopsy we have already seen. I will not be repeating it. And you will also have to assess what are all the non-obstructive azoospermia causes. It can be chromosomal abnormalities, Y microdeletion of the Y chromosome, normal FSH testicular volume, and sperm retrieval is reduced. These are all certain things that you will have to assess. How do you handle a specimen, be it an aspirate or a biopsy or whatsoever? They say that 3 into 3 millimeters is a minimum requirement. Just as you require this number of glomeruli for an adequate renal biopsy. Here also you find that this volume is required. And directly from the scissors to the fixative, I should not be carrying it between the probes of the forceps. There should be no compression. Bowen's fluid, Zenker's fluid, or Stave's fluid are recommended. Acetic acid, zinc formalin is another one. Formalin is not recommended because it causes a shrinkage artifact. And the section should be about 4 to 5 microns in thickness. Bilateral biopsy can be advised because of the variability between the two testes and also between different regions of the same testis. The stains that are routine HNE, the meson-strichrome, Van Giesen, Wiegert's iron hematoxylin, PAS for glycogen. So these are certain things which we will have to by heart. So take it from here to here, retain it, and reproduce in your exam. This diagram is of paramount importance, and these are the various stages. There is a spermatogonium, type A and type B. After which you have got the primary spermatocyte. There are 4 prophase stages. There is a meiotic metaphase, secondary spermatocyte, second meiotic division happens, spermatids, and finally a spermatozoon is being produced. And these again are the Sertoli cells which are pyramidal. And they will be in between the spermatogenic cells. They have got a central vesicular nucleus. Please have this mind. And again, the beautiful thematic diagram. This incidentally is one of the stains. I hope you people will be able to identify the Vegans and hematopsin. It can be used both in histology as well as the morphology of the spermatozoa. There are certain important germ cell abnormalities which have been given by the European Association of Urologists. There can be one, absence of the seminiferous tubules itself, or there can be the Sertoli cell only syndrome, which we have seen. Third one, there can be a maturation arrest, which can be incomplete, not beyond the spermatocyte stage. So initially the spermatocyte will be produced, but after that there is no further maturation. And hypo-spermatogenesis, wherein there is a marked reduction in the production of spermatozoa. These are certain things. When you give a report, you will have to report under any one of these columns. And this incidentally, it is showing predominantly the Sertoli cells, very little germinal epithelium, and there is a corresponding increase in the Leydig cells. So number them, remember them. Germ cell aplasia can be there, wherein there is no germ cell. These are the features of the Sertoli. There is a tubular outline that is maintained, resembles the prepubertal testis. Prepubertal testis. Minimal morphological change, variable hyaline cells can be there. And also, you should be having all these conditions in mind, which we have already seen in the tabular column. Worth remembering these. The next one is a maturation arrest. What is this? It can otherwise be called a germ cell arrest or a spermatogenic arrest, and it is better termed as hypo-spermatogenesis. The spermatogenesis is interfered in all the tubules. We will be seeing the primary spermatocyte, but beyond that, the maturation does not occur. It can happen in a case of gonadotropin insufficiency, radiotherapy, chemotherapy. It may be reversible in cases of heat or infections. Irreversible whenever there is a chromosomal abnormality or anomaly. R does not reproduce what we see, rather it makes us see. I would like you people to kindly explain this, what you are seeing. In one case, I find that these are all the epididymal tubules lined by tall columnar cells, and they are being filled with spermatozoa. So nothing is wrong within the testis if it is a case of infertility. In this case, there is definitely a maturation arrest. I find that there are Sertoli cells, there is some amount of maturation, but there is no teeming with the spermatozoa within the tubules. This can be variable at different tubules. Hypo-spermatogenesis. Spermatid is found in any tubule. There is a full maturation, but the total number of germ cells are decreased. And what are the causes for this hypospermatogenesis? It can be in a case of hyperprolactinemia, diabetes mellitus, undescended testis, varicocele, infectious orchitis, irradiation. Other systemic diseases can be cirrhosis, alcohol abuse, drugs such as cyclophosphamide, methotrexate, pesticides. 2 or 3 that you people can remember, just make a note of it. But since it is a good table, I thought I would display it for you people. Hyalinization of the tubule. This is another finding. We had seen a maturation arrest, we had seen a partial maturation arrest, and we have seen a Sertoli cell only. And what is this hyalinization? It is an end-stage testis. Remember, end-stage renal disease, almost like that. There is a sclerosis of the tubules. There can be peritubular as well as intratubular hyalinization. Look at this over here, it is peritubular, whereas here almost the tubules are becoming totally hyalinized. Sertoli cells also are absent. Klinefelter syndrome can be a probability. Fertility chances are very poor in such cases. I would like you people to compare the various pictures over here. Normal tubules over here, and in this one there is a hyalinization, And in some, I find that there is some amount of spermatogenesis, but in this, there is a total sclerosis that is there. And in this one, I find it is more or less predominantly Sertoli cells. I would like you people to kindly compare the pictures and look at the thickening of the basement membrane. This is a beautiful picture which I shall be revisiting in a different class. Great service, Shutterstock. And this is what I had been mentioning. So you people will have to mention about the normal dynein norms and what can be the abnormality. This is what we had seen earlier also. There can be mixed patterns. In some, I find a peritubular fibrosis. In some, there is a total sclerosis. Whereas in some of the tubules, there is a partial maturation. So they are more common than pure lesions as such. For example, Sertoli cell only syndrome or the hyalinous tubules. It precludes maturation arrest. Occurs in aging or involution. Peritubular fibrosis, sclerosis is seen. Sloughing of the germ cells and degeneration is noted. For example, look at this eosinophilic material. These are all sloughed off. And there can be a vacuolar degeneration of the epithelium. So this is a mixed pattern. It is not difficult at all. You combine the previous three patterns, it is a mixed pattern. And how do you interpret a testicular biopsy? The yield will have to be assessed. Uniformity should be there. Proportion, if heterogeneous. What is the diameter of the tubules? Whether there is any edema, granuloma, fibrosis, or inflammation. Dysplasia within the tubules. Kinking of the tubules. The tubule bends in a C-shaped or an S-shaped manner. This is given in one of the recent advances earlier. And this will prevent the motility of the spermatozoa. Leydig cell hyperplasia is almost the opposite of the tubular function. So kindly by heart this. Believe that life begins at conception and ends at birth. I thought I will put this quote more as an examination quote. There is no such thing as reproduction, only acts of protection. An important thing, a Kallmann syndrome. I just gave it as an MCQ. Students are finding it difficult. There is a defect from the sense going from the olfactory epithelium to the hypothalamus. The migration is blocked. Also, you find that there is a diminished production of the gonadotrophin releasing hormone, and there will be an ultimate infertility. This is called the Kallmann syndrome. There can be gynecomastia, and then there can be the clenching of the fist that can be present. And this gentleman was very generous enough to declare. This is the declaration given by him as a Kallmann syndrome, and this is a neurologist who has identified it. We have come to one of the last slides over here, and I hope you people, this is you. And what are you actually doing? You are facing an exam. And there is a curriculum which is an uphill task. Obviously, this is going to fall on you. And to prevent that, you got a small boulder called the university questions, which can temporarily stop it. We can master the subject later. Now, what is the conclusion that we can derive from today's discussion? Severity of the testicular abnormality will have to be assessed. Can the sperm be harvested for intracytoplasmic injection? We must remember that it is an office-based procedure where documentation matters, even at the forensic level. Mild anesthesia, sedation, and accurate biopsy are required for the interpretation. And this is one of the articles from which I had chosen the bulk of the material. I hope it will be useful for you people for the reading. And this is the very last slide, teeming with spermatozoa. We can improve our answers by doing this. Recollect the role of a granuloma, a lymphoma, autoimmune disorders such as mumps, Klinefelter's, cartilaginous, Kallmann syndromes, mucoviscidosis. What can be the other general causes? And any other question that is related to it. Crystalloids of Reinke that is mentioned over there. So these are modalities of improving our answer. I would like you people to improve it further. To be continued. Thank you.